Now, distinction between cardiovascular collapse, cardiac arrest, and cardiac sudden cardiac death. Cardiovascular collapse is sudden loss of effective circulation due to cardiac and/or peripheral vascular factors that may reverse spontaneously. Example: neurocardiogenic syncope, vasovagal syncope, or requirement intervention, that is cardiac arrest. Abrupt cessation of cardiac function resulting loss of effective circulation, which may be reversible by prompt emergency medical intervention but will lead to death in its absence. Sudden unexpected death attributed to cardiac arrest, which, if witnessed, occurs within 1 hour of symptoms of onset. A broad term that includes cardiovascular collapse. It is a broad term that includes cardiac arrest and transient events that characteristically revert spontaneously, presenting as syncope. Same as cardiac arrest plus vasodepressive syncope or other causes of transient loss of blood flow. In case of cardiac arrest, rare spontaneous reversions, likelihood of successful intervention relates to mechanism of arrest, clinical setting, availability of emergency medical services, and prompt return of circulation. Ventricular fibrillation, ventricular tachycardia, or systole, bradyle, pulseless electrical activity, non-cardiac factors like pulmonary embolism. In unwitnessed cases, definition is often expanded to include unexpected deaths where the subject was documented to be well within the preceding 24 hours. In case of cardiac arrest, it is rare spontaneous reversions. Likelihood of successful intervention relates to mechanism of arrest, clinical setting, availability of emergency medical services, and prompt return of circulation. So 40 to 70% is coronary heart disease. Myocardial substrates, example, they are myocardial scar, hypertrophy, fibrosis, myocardial stretch, electrical heterogeneity, ion channel function modification, and abnormal calcium handling. The triggers are heart failure or stretch ischemia, myocardial inflammation, vigorous exertion, electrolyte abnormality, environmental stress, psychological stress, and depression. Population-based risk factors, that is male sex, black race, diabetes, current smoking, hypertension, chronic kidney disease, ECG features of QT prolongation, QRS prolongation, early repolarization, and LVH. Family history of sudden cardiac death, diet low in N3-PUFA, polyunsaturated fatty acids, atrial fibrillation, obstructive sleep apnea, and heavy alcohol intake and low magnesium levels. Cardiomyopathies, the inherited arrhythmia syndrome like long QT syndrome, Brugada syndrome, CPVT, early early repolarization syndrome. Valvular heart disease account for 1 to 5%, idiopathic VF and others. Coronary artery disease, that is atherosclerotic coronary spasm or congenital anomalies, which pathophysiology acute MI, ventricular rupture, tamponade, ventricular scar from wheel infarction will present as polymorphic VT-VF, bradyarrhythmia, pulseless electrical activity, ventricular tachycardia, and ventricular fibrillation. Cardiomyopathy is dilated, hypertrophic, and ARVC infiltrative disease, valvular disease with LV failure. It presents as ventricular scar, ventricular hypertrophy or pump failure. It will present as VT, polymorphic VT-VF, pulseless electrical activity, and bradyarrhythmias. Congenital heart disease like tetralogy of Fallot, VSD, and others will present as ventricular scar from surgical repair and hypertrophy, ventricular trachyarrhythmias, bradyarrhythmias, and polymorphic VT and VF. This aortic stenosis will lead to obstruction of outflow, and ventricular hypertrophy will present as bradyarrhythmias, pulseless electrical activity, bradyarrhythmias, polymorphic VT and VF. Mitral valve prolapse or mitral regurgitation will lead to pump failure, or ventricular scar will present as ventricular tachycardia or polymorphic VT and VF. Arrhythmia syndromes without structural heart disease, genetic, it is long QT, Brugada, and CPVT will present as abnormal cellular electrophysiology, will present as polymorphic VT or VF, idiopathic VF, early repolarization, drug toxicities, acquired long QT and others, electronic abnormalities, electrolyte abnormalities like severe hypokalemia. WPW syndrome, there is accessory ventricular pathway, that is pre-excited AF or VF. Pulmonary embolism, not Recommendation for chest compression. Chest compression should be delivered at a rate of 100 per, at least minimum of 100 per minute. Each chest compression should depress the mid-sternum at least 2 inches, that is 5 centimeter, and the chest should be allowed to recoil completely to allow the heart to fill before the next compression. First responder should begin CPR with a series of 30 chest compressions followed by 2 rescue breaths. This compression ventilation ratio is continued until an advanced airway is placed, that is the endotracheal tube. Chest compression should be interrupted unless absolutely necessary. When possible, these performing chest compression should be replaced every 1 to 2 minutes to prevent shallow compressions from fatigue. The elements of high quality CPR is rate of chest compression should be at least 100 per minute. Depth of chest compression will be 2 inches. Allow chest to recoil completely after each compression. Minimize interruption in chest compressions and avoid excessive ventilation. So these are two rhythm strips of typical rhythm strip of VF, and this is appearance of fine VF. So this is an ECG causing torsion at the pointes, which subsequently degenerates to BF. Notice that in this case, the rhythm strip was recorded after the standard. Most ECG machines record them simultaneously. With torsion at the pointes, it is yeah, it's here. There is one normal sinus rhythm, then there is a pause, and there are broad QRS sinus rhythm, and then there are multiple VPCs. After that, the torus de Pointezor starts. This is the start point. This is the normal VRS complex. This is the pause. This is the polymorphic VPCs. And after this, there is a start of torus de Pointez.